So welcome. I'm Gail Rousseau. On behalf of the G4 Alliance, it is my absolute pleasure to welcome you to our first ever side event on the healthcare workforce. And we are absolutely delighted to have you here with us and delighted to have such an esteemed panel to share important thoughts about this important topic with us. If I could just say something about the G4 Alliance. I'm very proud to be associated with this organization and with every one of our 80 member organizations. We have a simple mission that is to do all we can to assure care for the neglected surgical patient. We want that care to be accessible to all, to be safe, timely, and affordable. And I know you all share that goal with us. We are delighted in the event this evening to be partnering with our good friends at ACGME, and I'd like to recognize their chief financial officer and CEO of ACGME. I'm so sorry I misspoke there. John Ogunki. John, would you like to? Do you want to say a few words?
Together, I wish my brother all to the thank we have a path forward to addressing population health and equity. Thank you so much. I do want to introduce a couple of my colleagues that are here. Dr. Jim Origi, who's the president and CEO of ACGM International.
Dr. James Origi. Joyce Price, who makes it all happen at ACGME. That's great. So as you can see from our slide, the Accreditation Council for Graduate Medical Education shares so many of our goals to improve healthcare and population health. And so this feels like a natural partnership. Yes, John. That's right. And that I knew that I had misspoke. So forgive me for that. He's just CEO in my book. And you are very, very pleasant to work with, John. And it's been an absolute delight to work with you and Joyce and Jim to put together this first event. So thank you. So without further ado, let's get started. We have a wonderful panel and I'll introduce them all briefly now, and then they'll come up and share their wisdom and expertise with you. Our first speaker will be Dr. Jim Campbell, who I think you all know is the Director of Health Workforce at the WHO. So we are very happy and honored to have him with us this week, which is probably the busiest day of the busiest week of his year. Next to him is Michael Bath, who is coming to us from Cambridge. Michael is a general surgery registrar at the University of Cambridge and is one of the thought leaders in the area of how we think about the surgical healthcare workforce ecosystem. Next, we have our G4 member society group, the Harvard Program in Global Surgery and Social Change. We have Dr. Key Park, who modestly is sitting in the audience back there and has shown his commitment to equity by having his chief fellow, who is Dr. Rashmi Junjunwala, who is going to be presenting her work and the Harvard group's work. And then last but certainly not least, one of the most important elements of all of this is how do we decide quality, right, in our healthcare workforce? And Dr. Ricardo Leon Borquez, who is the president of the World Federation of Medical Education, will be talking with us. Then we'll have some questions and answers, and then that promised adult beverage and some refreshments. So with that, I'd like to turn the podium over to Dr. Jim Campbell. And this is
So good evening, colleagues. Thank you very much, Gail, to our host, John, as well, panelists, some familiar friends and faces in the audience and new personnel. Great to be with you today. Yes, we've started World Health Assembly, 75th birthday of WHO. I hope you've been walking the talk or following the speeches earlier today. It's going to be a great week. Obviously, lots of issues alongside at the Assembly, which are going to be relevant to some of your discussions today. Progress on universal health coverage, the future of a pandemic agreement on emergency preparedness and response. And clearly, in terms of your occupational area of excellence, that response piece in many, many settings. A resolution also being proposed on emergency and operative care, coming further forward, sponsored by a few member states and already getting some traction to come further forward. So Gail invited me just to give you a sort of a big picture overview before we start to jump into some of the detail, and that's what we'll do. The world as we know it. We've used this slide for many years now, since we've been talking about the Sustainable Development Goals, just the complexity of the global challenges around healthcare. And we've seen the whole issue around antimicrobial resistance, around refugees and migration, conflict and displacement, whether that's climate related or conflict related, rising costs really coming through. Major challenges today with debt around the world. We're already seeing the economic bailout of countries, which is having immediate impact, 20% budget cuts in healthcare, which impacts the workforce, it impacts their wages, and it impacts the people not being recruited, ending up with unemployed graduates. All these challenges that are constantly there. We are now at the halfway point, 30th of June, 1st of July, the halfway point of the Sustainable Development Goals. What have we learnt, and what direction will we take in the future? And there will be three meetings in New York at the end of this year in September, where heads of state, not ministers of health, heads of state will be discussing what's the progress on universal health coverage, what's the progress on tuberculosis, and what's the issues around emergency preparedness, and what will we do better, what will we do differently for the second half of the SDGs, and learning from that. And this first part, public health emergencies of international concern, have actually dominated that. And we have, for the first time in WHO's records, we've seen reversal in life expectancy, the COVID pandemic, across high-income countries and some of the middle-income countries where the data is really up to date. We're seeing immunization has taken coverage for children, has taken an absolute belt. Will that translate into increased childhood illness, increased childhood deaths in the next couple of years, which again will impact the Universal Health Coverage Index coming on. So really quite concerning in terms of where we're at. Pre-COVID data, we were actually celebrating. We were saying, you know, we're still seeing this global upward progression, even if it's, you know, 2%, 3%, 4%, incremental improvement every 2 to 3 years, which is a sign of good quality. You know, we don't necessarily want to see 10% improvement in a very short period of time. We want to see this incremental, sustainable improvement that really says your health system is working, your prevention strategies are working, your palliative care strategies are working. So how are we doing that? We will produce new data, which will be published this month, May, of where we are now, the first progress report after COVID. It will be, some of this will be orally presented in the Assembly, and the picture is not good. Considering the COVID, we can celebrate some success, but the biggest issue is access to care is going backwards. And because of poverty, because of loss of employment, loss of jobs, people are not accessing care in the numbers thing. And this is not new. We've seen that around the world. So let's come to the workforce and what's the progress on the workforce. We continue to look at, with member states, their reporting and their data on an annual basis to try and look at that. In last year, and again, pre-COVID data, we looked at where the progress that had been made based on their 2020 data across the world. What we saw is that employment is growing in the health and care economy worldwide. High income countries rapidly accelerating. And so we'd anticipated that, but we benchmarked against a universal health coverage index to say, what is the sort of mean number that you require to cover at least 80% of your population based on these global improvements? And that created a benchmark of which we said is the UHC threshold. It's not a target. We're not saying to countries, you must have, because it's a dynamic, it's constantly moving. But where we see countries above that mark, they tend to have at least 80% population coverage for health services. Below that mark is when they get into struggle. And there's a new piece just published in the BMJ, which sort of accentuates that thing. What we see is that, sorry, that's backwards. We have back. What we see is that there is improvement, and we can anticipate on pre-COVID trends that we will see the global shortage reduce from 18 million to 15 to 10 by 2030. And that's positive. And a lot of that growth, though, is in Southeast Asia. When you then start to disaggregate in the Africa region and the Eastern Mediterranean region, we're not seeing the level of growth that we need to get that coverage index higher. So we're particularly concerned about a greater share of the shortage will be concentrated in fewer and fewer countries. And they're the countries which are furthest behind and with some of the largest challenges in the economics and the debt relief at the moment in time. So how do we look at that? So the 5th Global Forum we held last month, looking at all this evidence, looking at all this data, what do we need to be doing for the second half of the SDGs? And what we came up with in a consensus, over 4,000 people participated in the forum of 3 days from 160 countries around the world. We had about 200 people in Geneva, including ministers and heads of agencies. The consensus that came out of that was a fairly short set of actions that we can be building consensus around. Protect the workforce is most essential. Protect the investment. Don't reduce spending in health and care at this moment in time. It's going to have long-term impact on human capital for the future. So please continue to invest. Invest in the people that are there in their jobs and make sure accordingly that they come through, and really build our education capacity for the future and put that data and evidence together. So a couple of slides then just to say, what does that mean for this audience? What are we looking at, the surgical workforce in particular? So the surgical workforce is a grouping, it's an adjective before the workforce. It critically includes many specialists that we recognize globally and that are very easily recognized through the education and their license and the medical councils and their registration, but it also includes many other clinical occupations that are involved in elements of surgical care or preparation or theatre work, etc. So to understand what are we counting and what are we measuring is one of the first challenges that we have. Then to be looking at the quality, the scope of practice, the education, etc. If I look at what member states are reporting to WHO over the last decade, what you can see in this first column here on the left-hand side, over the last 10 years, 177 countries have reported data to WHO about the 3 specializations, over 90%. I mean, that's fairly strong. If I look on the right-hand side, that data, which countries are giving us contemporary reporting and data that we can actually use to inform national policy decisions, national policy dialogue. Do you have a shortage in your jurisdiction? Do you have a shortage compared to your neighbor? Do you have a shortage? Less than half of the member states are reporting on that. So we're really, in terms of having a position to really inform people what to do, what can you help us in terms of doing? This is the last slide. What action therefore can we do? Please help us to produce common goods for health. The baseline evidence and information that informs every national jurisdiction, their policy and planning process. Develop those partnerships, engagements at the national level, because that's where the evidence, the data, the policy debates are happening. The global thing is we're promoting good practice, we're promoting good guidance, but it's in the countries where it most counts. Standardize, just as within the surgical procedures, There are operating minimum protocols, clinical operating practice, standardized to the labor policies and practice, so that we're measuring apples and apples and apples, not apples, oranges, pears, salads, tomatoes, throw everything else in, to come further forward and really get countries to do their requirements of annual collection, reporting into the public domain for the policy dialogue, which then comes into the WHO process and is everybody's public good, which means researchers, scientists, policymakers, any publications, authors can use that data as a common good for health. We're not protecting it in different institutions, societies accordingly. And that would really be where we'd ask for your assistance, support
Great,
as the G4 Alliance. Thank you very much.
great. Thank you so much. Now, thank you, Dr. Campbell. It's now a pleasure to welcome Dr. Michael Bath, General Surgery Registrar from Northeast London, who's done a lot of thinking about this. He's far too humble, but when we are looking for a conceptual framework for how we should be thinking about the surgical workforce, we went to the literature as we do, and we came up with his paper. So we're delighted that he was willing and able to come join us and discuss it further. Michael?
Thank you so much.
You bet.
Yeah, thank you very much for having me. As I just mentioned, my name's Dr. Mike Bath. I'm a surgical registrar in London, but why I'm here today, the work that we've been doing as part of the Health Systems Design Group in the Department of Engineering in the University of Cambridge. And it's an honor to have today's session based around our paper that we published a few years ago on BMJ Global Health. I feel not only as will I talk today about workforce, but also how we should be really rethinking how we approach global surgery as an entity. So global surgery really has only gained full momentum, we feel, following the Lancet Commission. And as we would define in simplest terms, global surgery is the provision of providing improved and equitable surgical care to the world's population. Now, normally and previously, historically, this has been defined as or centered around pure metrics, data, and definitions. But from what our thinking and what our paper aligned to was that this needs to be revised. We need to think in more of a public health strategy with all of this. To develop and improve surgical care globally, we propose 3 core tenets to focus on if we are to we propose 3 core tenets to really focus on to make sure the aims of global surgery are met. And these tenets are need, and their access, and their quality. These should not, though, be seen as discrete entities within it. These are 3 tenets that work together. All of these should be developed together if we are to work with, if we are to achieve global surgery goals. They form a complex system such that if this care is to be achieved, all of these areas must be targeted. I will be discussing each of these need, access, and quality in turn. But what we must do is move away from thinking global surgery is focusing on one disease with one intervention for one outcome, but thinking all of these areas must be developed together. So looking at needs. Now, we know there's lots of studies that have provided high-level estimations on surgical care on that sort of macro scale. But often these estimates don't tell the true story where the actual need is. There's often a lot more nuance and complexity to this. We take trauma surgery and trauma care as an example. Yes, we know there's a lack of trauma surgeons worldwide, but if you take the trauma journey for a patient, not only is it getting from the scene of injury to the hospital and the transport that's there, it's the infrastructure that's needed, it's the workforce that are there, and it's the following rehabilitation. There was an interesting study published a few years ago that said in regions that don't have an ambulance service, if you increase the number of trauma surgeons, that does not lead to better outcomes. So if we are to really understand need, if we really are to understand need better, we need every axis of that surgical journey covered, not purely on the number of surgeons that are present, but every bit of that workforce. This will allow for much more targeted approaches. We then move on to access. Now, access is a huge topic, and we could, I'm sure, discuss for hours, and hopefully the panel discussion later, we can talk on access to surgery. But we found that access to surgery is often limited by services that lack capacity, the workforce gap, which we'll be talking about later, the financial costs that are involved, and simply geographic distribution of the healthcare centres. But we all know that no surgical service can be functional without the appropriate staff, with the adequate facilities in the reach of the population, with appropriate funding. And all these 4 areas must be targeted. All these 4 areas as well are largely in control of by governments. So where do we sit in as a global surgery community? If these 4 are controlled predominantly by governments, how can we influence this? Well, actually, these services and the planning of this should not just be politicians involved, but we should be having these discussions as researchers, as clinicians, economists, and patients to make sure these areas are targeted. And the final aspect is quality. Now, relatively little is known in proportion to the other 2 tenets that I talked about regarding the quality of surgery globally. And we've seen it's often a neglected area of focus of research. Even if we improve the access to surgery, the workforce available to those that are in need, if the quality is not there, then our standards will remain the same. Now, studies are slowly unpicking where this quality, where the lack of quality arises from. The African Surgical Outcome Study, the Global Surge Study, they're unpicking this. And we know that perioperative mortality is 7 times higher in resource poor settings. So clearly there's a lot more to this. Anesthesia is a great example of this, and this is seen as particularly lacking behind. And this then links in back with the workforce. There's a lack of advocacy for increased quality within anesthesia, where it's often seen as a technician role. Going back to the need, we can link that quality and access back in to the need that high quality anesthesia can be achieved by non-physician anesthetists, depending on the relevant scenario. If your region and your needs basic surgical care, emergency general surgery, hernia surgery, then you can have high quality care by using non-physician roles. However, if your region requires tertiary neurosurgical care and that's your goal, then clearly this isn't sufficient. We also talk about infrastructure and the equipment that's present that's centered around quality as well. We know that a huge amount of the donated, infrastructure and equipment in many developing countries comes from higher income settings, but much of this it does not work, and a lot of it is never used. This then links back to your need and access. So if our standards of surgery are to improve, ensuring the quality remains key. So in summary, we are proposing that global surgery should no longer be viewed simply as just the metrics and the data that's produced, but it must be reviewed by these core tenets of access, need, and quality. This is a very complex system. All of these areas are interlinking, and each one can't function without the other. I mentioned earlier, we can't simply focus on global surgery as a single condition with single outcomes. We will never get the response that we want. Instead, we should think about global surgery as a horizontal system that should be strengthened across the board if our outcomes are to be achieved. So how is any of this useful? Why am I here today to try to get us to rethink how we should approach global surgery? So firstly, the awareness to the national and international bodies that they should be aware that they need to develop equally across these 3 tenets, and that's the only way you're going to improve care globally. Funding groups must realize that a single intervention for a single condition is unlikely to cause any large changes to morbidity and mortality outcomes. It's those wider scale developments that are needed across need, access, and quality. And charitable groups and NGOs, many of which from the G4 Alliance, we must make sure that we work together and focus on all these different aspects so that this global surgery goal can be achieved. Thank you very much for letting me speak today. Thank you very much.
Thank you very much, Dr. Bath. Now it's my great pleasure to invite up to the podium Dr. Rashi Jhunjhunwala, who is the Chief Fellow at the Harvard Program in Global Surgery and Social Change. Welcome. Thank you.
Okay. Hi, everybody. It's a pleasure to be here. As Gail mentioned, my name is Rashi Jhunjhunwala. I'm a general surgery resident at Beth Israel Deaconess Medical Center in Boston, but I have been taking a bit of a hiatus from my surgical training to work with the program in global surgery and social change on all issues global surgery and equity. And actually, Mike, I just wanted to say thank you because you really set up my talk really well. So thank you for that. So, one of the things that we all probably can recite in our sleep is the Lancet Commission, first of all, the tagline, and then also some of the indicator targets. So, the Lancet Commission published in 2015 and created, a set of 6 targets, indicators that we need to work towards achieving. And the target for the workforce indicator was that we want to have at least 20 SAO specialists per 100,000 people in 100% of countries by 2030. So that was the goal. At the time of the commission, this is just a map from the commission paper that shows us the distribution of workforce providers per 100,000 across the world, right? So the white and the lighter colors are fewer providers per population. The dark colors seen mostly in Europe are high density. So one thing I just wanted to point out is that the data that is represented here is largely based on modeling studies or on projections, right? Based on some data that largely came from like the early 2000s. So you want to say, you were thinking, okay, that was 2015. So what is actually being done to determine this? So these are some numbers. I'm not going to read them all, but you think about Somaliland is 0.8 per 100,000 SAO specialist providers, and that's as of 2020 paper, and then up to Colombia being at 13.7 per 100,000. And then just to point out, I'll talk a little bit later about rural versus urban, but India in a more recent study that just came out in terms of assessing the indicators only has 0.385, can't even read that number, so low, per 100,000 population in rural India, which really shows us these are real numbers that are being captured in response to trying to understand this baselining, and they're low, they're not reaching the targets, right? So just to even further subspecialize, as a nod to Dr. Key Park and Dr. Gail Rousseau, neurosurgery and specialist surgery providers are even fewer and far between. So in neurosurgery, there's a gap of 23,000 neurosurgery specialists that are needed to meet the 5 million unmet operations that are needed in neurosurgery. For pediatric surgery, even in high-income countries, there's two pediatric surgery specialists per 100,000 kids, as low as 0.03. I don't even know how you measure that much of a person, but that much per 100,000 kids in low-income countries. And then, according to the WFSA anesthesia workforce study from 2017, 77 countries are reporting a density of anesthesia providers, specialist providers, less than 5 per 100,000. So that's quite a few countries that do not have adequate anesthesia provision. But I wanted to also talk about those absolute numbers, and this is what I'm kind of talking about. Mike, you really set this up, which is huge. Didn't know that, but I'm really glad that you did, because the absolute numbers and the metrics that we assess are not really useful if we don't actually look at what that means for the populations that we're talking about, right? So as is true across the world, regardless of income level, specialists tend to aggregate in cities. And so when you have that number of 0.03 or 0.8, private SOA providers in Somaliland, that is probably also even more unequal when you think about where those providers are located. So they might be highly concentrated in cities, they might be in Hargeisa, they might not be in the rural areas that are also where patients are in need, right? And then some of you might have heard some other data from a study that I've been working on with my colleague Jen Han in the audience, and also under the tutelage of the inimitable Dr. Mikasa, surveying the SADC states about their National Surgical Obstetric and Anesthesia Plan implementation and development. So in the free text responses, this is some of the responses we got for the weaknesses of the surgical capacity and workforce in the countries in SADC. And I just want to highlight that the respondents, the SOA stakeholders are saying there is maldistribution, with the majority of SOA staff being in the big cities and tertiary facilities and not enough in district hospitals. Also talking about the fact that there's just unequal access for rural patients all across these countries. Some people have talked about brain drain as a component of this. Professor Peter Donker, the president of WACS, was just talking about brain drain being a huge issue for surgeons trained in WACS, and how people are leaving Nigeria, leaving other parts of the wax community to seek better opportunities in other places. And one of the things that Prof. Donker was even mentioning in this article that is pictured here is that part of this also has to do with increasing the sustainability and the conditions for providers living in rural areas. You're not going to take your kids and move to a place where there's no schools for them. That just isn't going to happen probably unless you're, very willing to leave your kids somewhere else. But that's, creating an environment where people are willing to move to a place of need is also a huge part of this. And, just as on the flip side of this, this conversation, the COSEXA put out a paper in 2017 that actually also assessed the end location of their trainees. And in contrast to the experience reported by WACS, COSEXA actually found out that 88% of their graduates stay in the COSEXA region and 93% stay within Africa. So there is some nuance here, right? And I think part of that goes into the conversations about what is the issue. These metrics that we're measuring might be high quality, but they might not reflect actually what's going on, or it doesn't necessarily even mean high quality. We'll talk about quality in a bit. And then one other thing I just wanted to bring up is how do we define the SIO workforce? So we're talking about who we have and counting these numbers of who it is that's providing SIO care. And in the Lancet Commission, there wasn't really a definition given for who counts as an SAO provider. In 2021, there was most recently the Ustein Consensus on Global Surgery Indicators, and they really worked on defining what these indicators are, what they mean, and what the definitions are of them. And for the workforce consensus update, they really defined active practicing SIO providers to be, certainly the certified specialist physicians that we kind of traditionally think about, but also included people like specialist physicians, so GPs who are providing surgical care, and this happens largely in district level hospitals, non-physician, non-specialists, so those are like the nurse anesthetists who provide a lot of the anesthesia care a lot of places, and then any other SAO relevant practitioners, but they notably did exclude trainees of any kind from the definition because the trainees shouldn't be seen as the actual workforce because they are in process, right? So just the same way as I, don't really count as a person in my hospital system, that shouldn't count for anyone. Oh, thank you so much. That's nice. And so, when you think about that, task shifting can be a solution to this, right? We think about, okay, if you don't have the traditional, a surgeon, an anesthesiologist, or an OBGYN, can we shift some of these jobs to people who are qualified in that they have medical knowledge and they can be trained to do these procedures? So, we know that associate clinicians provide the majority of SAO care in low-income countries. And just as an example, in Sierra Leone, they increased their number of nurse anesthetists by 72 people, and added 31 surgical techs, and that increased their SAO workforce by sixfold, right? So that's a big increase, and that's a lot more access that's being provided. And then just another quote in the flip question, which was, what is the strength of surgical workforce or the surgical system in your country? One of the respondents to the SADC survey mentioned that they were able to provide safe cesarean sections in all district and provincial hospitals. So I just wanted to close with some of these questions that I think we can talk about if you guys want in the Q&A, things that I've been thinking about with this issue, regards to this issue. How can we increase efforts in SAO education, both in terms of specialists and non-specialists? How do we work on mitigating internal brain drain from the cities or from the rural areas to the cities and vice versa, and also, outside this country itself? How can we develop and measure outcomes for task shifting so we can actually know whether this is resulting in reduced quality or improved quality or the same quality? And then also, how can we innovate? So potentially, do we even need 20 SAO specialists per 100,000 people? I don't know. Maybe we can increase care with fewer numbers by using technology like telehealth or all these kinds of things. I'm not an innovation expert, so I will leave that one up. But yeah, that's just some of the ideas that I had in terms of addressing these gaps. So thank you very much.
Great.
Yeah.
Thank you very much, Dr. Jinjanwala. And now to our, to complete our panel portion of the conversation, I'd like to welcome Dr. Ricardo Leon Borquez, who is, as I mentioned earlier, the president of the World Federation of Medical Education. So he knows quality when he sees it, and he's going to explain that to us. So thank you and welcome.
Okay, well, thank you for your nice introduction. And I want to take this opportunity to tell you that I'm here with my companion, the Vice President of WFME, Dr. Mounier, that coming from Canada, okay? So,
And you have some slides.
okay, there it goes.
Mhm.
Okay, so we're going to be talking about the name of this event is Suturing the Gap of Global Workforce for Surgical Care. So, but in order for you to understand what WFME does, I have to give a brief introduction. And I have to say that that we are aiming to enhance the quality of medical education and to promote the highest standards for the quality of medical students. And it's in a partnership organization that has the world's 6 regional medical education groups. And we are working with 2 founding members, that is the WHO and the World Medical Association, and 4 executive members, that is the Junior Doctors Network, that comprises the residents of all the trainings, the International Federation of Medical Students Association, the Association of Medical Education of Europe, and the CFMG, they all you know about it. And we were founded in 1972 by our 2 founding members, as I mentioned, and we have the 3 main priorities among many others. And this is the promotion of accreditation through WFME recognition program. We have rising the standards for basic medical education, postgraduate medical education, and continuous professional development, and maintaining the World Directory of Medical Schools. So this is the main things that we produce or that we work with in our federation. Now, when I talk about federations, you have to understand, as an example, we have the first one there that says the PAFAMS. Okay, that's the Pan American Federation of Associations of Medical Schools, and they represent each country on the orange part, from Canada all the way down to Argentina, because every country has a medical schools association. So that association represents all the schools of every country. So we are all together being represented by one organization. In this case, PAFAMS is for the American continent. We have the Association of Medical Education of the Eastern Mediterranean region that represents the region that it's under the blue color. Then we have the International Medical, the Association of the African Schools, okay, that obviously is represented by the yellow color. Then we have the Association of Medical Schools of Europe that is represented in the light blue. Okay, then we have CERAMI, that's the Southeast Asia Regional Medical Education Group that is represented in the green. And then we have the Western Pacific Association of Medical Schools. So this is how we are distributed. Okay, and our executive members, as I have mentioned, it's ECFMG, WMA, WHO, IMSA, and AMI. And this is the last picture that he took a month ago, okay, where we had our executive committee meeting, and it took place in Quebec. And that's where we are planning and doing all the stuff that we normally do. So if you go into our webpage, this is what you're going to find, enhancing the quality of medical education. And we work, as I mentioned, accreditation, standards, and World Directory. Okay, so now the G4 Alliance is asking us to, as you know, improving the access to maintaining the quality of education and training required to continuous learning amongst multiple scholar stakeholders. And they're concentrated, as we said, in surgery, obstetrics, anesthesiology, and they want to produce high quality personnel to support the needs of the world. So they have needs for the public health and policy. They're concentrated in access, cost, capacity, and culture, and quality, safety, and effectiveness. Okay, so probably that's where we fit more in this talk. And what we have done through the years is we have developed standards. Okay, so the standards of the WFME are the highest standards for quality of medical education. And we have standards for basic medical education and postgraduate medical education. And as you can see, there are based on 8 elements. Okay, the only difference between both of them is one is concentrated on students and the other one is concentrated on the medical doctor. And we have the continuous professional development. Okay, and here we have a different setup of the elements because there's so much variety among all these organizations that take care of this process. But in general, we're trying to continue with the quality. So let's concentrate a little bit on the postgraduate medical education. And so the WFME standards were developed to ensure that they can be applied in all contexts and circumstances. So that's very important to understand. Okay, because this is very easy to say, okay, here we have London represented. Okay, we have Singapore, United States. But what happens in poor countries? So we have to be working on the context. Postgraduate medical education as a social science tends to follow socially constructed values and ideas rather than being a primary evidence-based discipline. That's totally understandable, I guess. It varies between social and geographical contexts and is influenced by culture, epidemiology, healthcare systems, and material and human resources. We have been seeing human resources are very variable in every region and every country. And the culture has a lot to do with all the way that we train students. We encourage to consider what is appropriate for your own context and what might improve your own current practice. And we might suggest that postgraduate medical education programs could effectively contribute to the improvement in population health and patient outcomes. Now, the standards address the elements of postgraduate medical education, which encompass the totality of all progress and activities offered to facilitate postgraduate doctors' learning, well-being, achievement, including the management of quality improvement in medical education programs. And if we go through the different elements, we would know that the most impact that WFME can have in order to improve the quality of all these things is a level of the curriculum. So we have to put a curriculum in which we make conscious how this is going to affect the student, but also the curriculum has to be set up not only by the residency training process, but also by the governments. Because normally it's the government's the one that pays the hospitals to support the residents. So the curriculum has a very important issue to go through. So at postgraduate level, the curriculum is it might be defined as the managerial, ideological, and planning document that should inform the postgraduate doctor what to expect, including the entire requirements, length, and organization of the program and its flexibility. The assessment system, the method of postgraduate doctor support, promote and define appropriate outcomes of postgraduate medical education that will have an impact on the health of patients and communities. Advise the teacher and supervisor what to do, deliver the content, and support the postgraduate doctor in their task, and personnel and professional development, and advise the postgraduate doctor what to expect from the teacher and supervisor. And also enable the responsibility body for set appropriate assessment of postgraduate doctor's achievement and implement relevant evaluation of postgraduate medical education provision. Recognition of the role of experimental, self-director, and opportunistic learning in postgraduate medical education, and enable their integration into the training process. Inform the society how the program is executing the responsibility to produce the next generation of specialty doctors appropriately. And probably the best way to do it is that we have to convince the presidents of each one of the regions of what this group is trying to do, the G4 group. So what I probably will do is present what the task that we're trying to achieve, because now I'm part of this, okay, and present it to the presidents of the regions so they can send it to all the countries and to all the medical schools in each one of those countries. And if you want to know more, go to our webpage, wfme.org. You will find the standards, and you will find all this kind of standards so that you can be more aware of what we're doing. And if you have any questions, please contact me at my email. Okay, so thank you very much.
Well, thank you very much, Ricardo. Well, now we get an opportunity to hear from you. It's really a wonderful chance to ask people who are working in this space, doing research in this space, doing accreditation in this space. So we have microphones, 2 in the middle, 1 on either side. And although we have questions here, we certainly want to give priority to our audience. So Professor Richard Henker from University of Pittsburgh, why don't you lead off?
Test.
There we go.
So Dr. Beth, one of the studies that we recently published with a group in Cambodia with Ministry of Health and FHI 360 is we looked at nursing workforce density and education level of nurses and the impact that it had on under age 5 mortality and life expectancy. And we found some associations there. I couldn't help but notice in your model, there was nothing related to nursing, but you did include public health. And I don't know, maybe you don't work with nurses very much in the UK.
I think more from the workforce aspect in our access area. When we say workforce, very much defining not just doctors, it is the nurses, the physiotherapists, any form of therapists that are there. I use the example of trauma is a good example to really to discuss this further, where workforce is just so important. I'm part of the health systems design group. So systems design is a big thing for our group, saying that trauma starts in the community and ends in the community. Yes, there's a very small window of healthcare where they're in a hospital, and in that hospital, yes, there is a doctor, there are nurses, there are anesthetists that use them, that are involved in patients' care, but actually it is getting them to hospital, the rehabilitation. So yes, I didn't mention specifically nurses, but of course, within that workforce, there's a huge range of people across all that patient journey.
It's great. I'll ask each person who's at the microphone to identify themselves, Rahel, and ask your question. You're next.
Yeah, hi. My name is Rahel Nardos, and I'm from the University of Minnesota. I'm also a urogynecologist, so I work a lot in the women's health area. So I just want to make a couple of points in terms of, the pressure between increasing health workforce and the compromise that puts countries in terms of quality. And I just wanted to give an example of the things that I'm observing on the ground, so that we're kind of grounded when we are talking about these issues. So for example, if you go to a lot of university hospitals that are training the next generation of healthcare professionals, including some of the mid-level providers, because of the need for task shifting, you will notice that during rounds on a patient, there will be 20 learners that are trying to learn bedside patient care from one faculty. Half of those people are outside of the patient room. There's no way that those people are actually learning bedside clinical care. And these are the people who are then going to graduate and go out and take care of our patients. And I've seen this a lot in obstetrics, actually, because there is a lot of task shifting in obstetrics where C-section is one of the most common procedures done in a lot of places, especially in rural hospitals. And it's being done by these people we're training. And when we ask, universities to increase the number of trainees, usually the way it works is, we want you to double the number of medical students. We want you to train more health officers. We want you to train more GPs, but there isn't the mechanism in place to actually provide the resources, the folks who actually are doing the teaching, right? So I think I really worry about that. And when we are seeing in terms of the actual outcome for patients is if you look at obstetrics, for example, we are actually decreasing the number of obstetric fistulas from obstructed labor, because we're increasing the number of people who are actually accessing care. But guess what? The number of iatrogenic injuries that are happening during C-section to the bladder, to the ureters, death from, infectious complications from bleeding is increasing. And that's because of the quality of education. And I'm just kind of curious, how we are, holding countries accountable for that. That's one big question I have. And another big question I have is, when we're seeing a lot of great healthcare professionals not wanting to rural hospitals to practice, a lot of that has to do with pay equity, actually, right? Because most governments don't reimburse healthcare professionals that well. And so what they do in cities is that they actually have private practice on the side. That's how they actually supplement their income. They have to. There's no other way to do it. But if you send them to rural hospitals, they can't actually have private practice because a lot of the communities can't actually pay out of pocket. And so when we're trying to get these people that we're training in academic institutions to go and practice in rural communities, they have so much passion for that community. They want to help, but they can't afford to do so. So again, I really want to see how organizations like the WHO is holding governments accountable for some of those things, for pay equity, so that we can actually solve the problems. Thank you.
Go ahead.
I think so. Apologies, ladies and gentlemen. I'm going to have to go to another meeting, but my colleague Tina Kunjaman will sit up and be part of the panel. But if I can just briefly make a point to that intervention, so many issues that you raise in there.
Yeah.
But part of the challenge that we've got the World Federation of Medical Education, we've got the International Council of Nurses, we've got the World Federation for Surgeons and Anesthetists. We're working globally. And yet a lot of the language that we use is very dominant Anglophone English things. But just as a normative role at WHO, we just got a couple of points just to point out before you go back to some of the other issues. An apple is not a non-orange. Yeah? A nurse is not a non-doctor. Yeah? We have to call people and roles and responsibilities what they are not. So we really need to get this working with you. That's an invitation, working with you to get this language right. And then similarly, if you're in a team, if you're talking about a grouping, which you are in terms of the needs and access, you can't shift a task outside of the team because nobody delivers it.
Right.
You can look at the scope of practice within the team and the roles and responsibilities, the clinical supervision, the delegation, the optimization of the team, but you can't shift a task out of the team. It doesn't get done. So task shifting, let's leave that with the advocacy people rather than the scientists. Yeah, thank you very much, but I'll leave you to that.
And let's okay, that's great.
Macassi wanted to ask a question.
You have Emmanuel.
For Emmanuel, of course. He's one of our biggest champions.
Thanks. It will be an easy one. So thank you so much to the panel for the excellent presentations. And I'm going to give you something very practical. My name is Emmanuel Makasa. I lead the Regional Collaboration Center.
Manuel, could you speak up just a little bit? It's a
Yeah.
bit hard to hear you up here.
Sorry, I'm saying
Thank
my
you.
name is Emmanuel Makasa. I lead the Regional Collaboration Center for Southern Africa, 16 member states in Southern Africa. And I chair the Technical Experts Working Group, which is a policy advisory to the 16 member states. So we've been trying to implement and work with the governments to help them, formulate their national surgical healthcare policy, and then move on to implementation. And obviously, in the whole policy formulation, we do assessments, and one key pillar is health workforce. And obviously, yes, we don't have enough, and obviously they are trying to make efforts, and obviously we have recognized the crowding and the quality that has gone down in the initial phase. But we've also noted other problems with the system. And this is mostly pointing to the inefficient use of what's there already. We have enough that we can do a little bit more. And we actually the goal is that we want to provide healthcare, surgical healthcare at the district hospital. Now, we are struggling to see governments are committed, they formulate the policies, but then they're not following it through to break down the establishment. What we call the establishment is basically in a health system. If we have a district hospital in a specific place, we say what it should have in terms of health workforce, how many surgeons, how many what, like that. And in the current scenario, in most of our region, there's no appointment, there's no positions for surgeons at the district hospital. And yet these are countries that have actually formulated these policies that they want to implement. And we're struggling to push that because again, then they push back and say that, well, it's gonna bloat the wage bill. At the same time, they want to provide care, but then they say it's gonna bloat the wage bill. And then they say they want to create employment. And we're telling them, you have gaps in here. Open up the establishment so that you can create those positions. And then obviously you create employment. And then you can also ensure that this service is provided at the district hospital. Now, I was waiting to talk to you because we want to understand how can we work together? Because we've done a lot this side, but we need your voice as WHO. You've been silent. You've been too quiet. No, for real. How are we going to work together to guide these member states to actually deliver on the ground? Because yes, there are opportunities. They can tap into the efficiency they have, but they need to open up the establishment so they can actually create jobs in those places so we can actually deliver care at the district hospital.
Thanks very much. So I'll rise to that challenge. Emmanuel and I have collaborated for many years on the surgery and the surgery resolution and all this work. In 2016, WHO with Dr. Margaret Chan convened the High-Level Commission on Health, Employment and Economic Growth. We had the head of state from South Africa, the head of state from France, 2 presidents. We had Nobel Prize personnel, the president of the International Council of Nurses, and many, many others. And we looked at exactly this issue, which is the 30-year dominance of macroeconomic thinking on wage bills in education, health, and social protection, and how what was previously the IMF positionality in terms of limiting public expenditure on wages as a percentage of GDP and forcing that onto the new democratic institutions across the world, how that has now become embedded within your ministries of finance, your Ministry of Economics, your Ministry of Labor. And so a health minister continuously faces that challenge. So we deliberately took that discussion out of WHO to the United Nations General Assembly. And the recommendations are very clear, black and white, what should be done. Published by the UN General Assembly, the World Health Assembly, the OECD, and the International Labour Organization, again and again and again. Put it up there. Protect the people, protect the investment are the 2 first things you do. Look after today's workforce before you think about tomorrow's and creating those jobs and everything else. The reality is, Emmanuel, it's politics, it's not evidence. So I can look around many jurisdictions today where this issue is dominating political discourse, and Treasury are not opening up the allocation of fiscal space budget expenditures to health, education, social protection. If you go to an education meeting, teachers have got the same problem. You go to social protection, care workers have got the same problem. And why is that? So the accountability comes back to, not to WHO on this occasion, I'm sorry. WHO is the member state, not the Secretariat here, it's the member states that convene this World Health Assembly, 194 of them. They are the decision makers. The evidence is there. Will the politicians stand up, the members of the World Health Organization, to these healthcare needs, equity, universal health coverage? We've put so much evidence into the public domain. Please use it to get decision makers to take action.
Thank
Thank you.
you so much. Wow. Thank you so much. It sounds like the answer is vote. Go home and vote for people who are going to protect federal sovereign budgets for employing healthcare workers. Welcome to the podium. We're delighted to have you, Tima. Dr. Gell.
Adrian Gelb, World Federation of Societies of Anesthesiologists, University of California, San Francisco. A couple of comments. Thank you, Rashi, for mentioning the Utstein metrics, so named by the abbey at which the meeting took place, Utstein Abbey, in Norway, for those of you who don't know. And the process was to extend the Lancet metrics, give them timelines and disaggregation. I'm pleased to inform you, Utstein 2 has taken place. We've created metadata sheets, data dictionaries, and we included in that funding 2 pilot projects. One running currently in South Africa, was on a competitive basis. I was concerned we'd get no applications. I was amazed that we got 18 applications from around the world. One's running in South Africa, one's running in Ghana, both involved the ministries of health. That was a requirement. To the rural issue, there's a body of literature on why people will or won't work in rural areas. Colleague of mine, Tyler Law, and Janet Tumakundi in Uganda did a survey in Uganda on rural work. The interesting finding, consistent with the literature, is that it's not about money. It's about the quality of the work environment, was number 1. And 2 was loneliness. I need colleagues. If we're going to hire into rural communities, there needs to be decent quality of work and environment. I was recently in Brazil, and I was fascinated and appalled that in the Amazon region, 78% of hospitals have no ventilator in the operating room. I mean, for us, you can't buy an anesthetic machine without a ventilator. It obviously involves some effort to do that. But who would want to work in an environment like that? So fixing the environment and then dealing with the loneliness seemed to trump issues of salary and my children's education, which was surprising.
That's very interesting.
And then a question for Tina. It was for Jim, so I apologize on Jim's behalf.
You're in the hot seat now, Tina.
It seems every time I'm here to speak with Jim, he delegates to you. But the question is really about how we should be reporting numbers. Jim reported workforce in absolute numbers. Rashi used the Lancet commissions by 100,000. Also pointed to Sierra Leone. We've just submitted the updated global anesthesia workforce survey and struggled with how do we do the arithmetic. Sierra Leone has increased their anesthesia workforce by 260%. They still sit at about 0.03 by 100,000. So it's an enormous achievement that's gone nowhere per population. And I'd be interested in how the WHO would like us to think about workforce, absolute numbers per population, or some other metric. Thanks.
Go ahead. Yeah, please do.
It wasn't as tough as I thought you would ask. All right, so I think I agree to most of the things. There are several initiatives that have worked, from the rural retention guidelines that were published early in 2010 and then a revision now. There are different cultural aspects, socioeconomic aspects, family and relational aspects that really influence retention. But primary, often for most people who are in a profession, it's really about, can you do your job well? And if you have the resources, then it works to a certain extent to mitigate brain drain. But I wouldn't call it brain drain. It's not, yeah, you're not draining, but moving out and not, you having a vacancy and this turnover of staff, etc. But to come to the question on how do we count, and this is really something that in 2016, was it, when the global strategy of the Human Resources 2030 was launched at the Assembly and adopted by the Assembly, there was a specific urge to all member states to report to the WHO, and this was the first of its kind, to report data to WHO through the National Health Workforce Accounts. And we've been working with the team, Roy's team, it was Walt, and before Walt, it was Mina. And we've been working with the team to really, and Adrian, you're part of the work. We've worked with Lund before. The understanding is, yes, you need to count your head counts. You need to have your head counts. But then you see, you do your head counts, but what does it really matter if you have a population that is 100 versus a population that is 100,000? So you need to have the densities to understand really, are we really, if you want to compare across countries, yes, density is the measure to go. But is it enough? And this is where it's a challenge and a question to all of us. And what we're realizing is we've always made head counts and densities. It was good at the global level, but really the national and subnational levels. Is it fine to just have a head count? Because you might have one surgeon who works half time. You don't have one surgeon, you have half a surgeon and will do half the services. So it's really down to FTE then, which really complexes the situation. It's harder as it gets to the ground, but it's easier to aggregate up. So we can have a discussion on that. But if we are more interested, there is a National Health Workforce Accounts that we have a handbook, we have denominators and numerators, and we're trying to standardize that. So that was one of the slides that Jim Ashley mentioned, to work with the NHWA focal points in the country who are reporting to WHO. So we're all having the same metrics and the same measurement indicators. That's the way to go.
Great. Yeah, thank you very much. Professor Caceres.
So my name is Suturing. I'm a pediatric neurosurgeon from Costa Rica. I have a threefold question. I hope it's not too long.
Can you all hear him? Okay.
Yeah.
So my first question, or my first comment, is on behalf of my wife, which, looking at the slides, she's a clinical health psychologist. So at looking at SOTA, she suddenly said, where is mental care embedded in this whole system? Because I think it's very evident during the pandemic, the huge mental strain, not only on health workers, but on the population. How much are we doing to reach that, to fulfill that gap, which is real? And, most of the patients not only have this physical component, they have this mental component that we have to reach out and fix. So it's very—
You want to let them take them one at a time, just since there are three. Mental health. What should we be doing about that? Anyone want to take that?
I can try.
Okay.
Because I can tell you what we did, and we did try, and the Health Workforce Department. So during the COVID, we tried to understand, because there was burnout, there was stress, there was lots happening. There was no evidence. We knew it was there, but we didn't have enough substantial evidence to know what to do. So we tried to initiate a simple survey back down to our countries, but it didn't come up. So the culture around, I think it's really about the culture. It's a culture about understanding that it is not to be set aside, but it is to be integrated within. And when you educate someone, and this goes down to the curriculum and education, it's just not about having your clinical and your operative care and your protocol, but it's back to the patient and the caregiver. And it's really that symbiosis that it's not one to be ignored. And I think there's more awareness about it.
Okay. Second question, and that involves governance. So we might agree on some point. Let's say we agree that we should fortified micronutrients with folate and some other fortification agents. And we might vote for it, but how is there accountability that those member states that agreed to do it finally do it? And the best case is folate fortification. So the whole Latin American region has signed up and agreed to do it. But finally, we found that only 2 countries in the whole Latin America have actually implemented it effectively. So how can we reach accountability for these countries to actually, do whatever is need to be done?
Yeah, so this is something that I know that we're all concerned about, and it is the basic enforcement of resolutions taken at the WHA, right? And we have one that's near and dear to our hearts, which is coming up for a vote this week on micronutrients, particularly highlighting folic acid fortification to prevent spina bifida. Could you speak about the general issue of how could WHO keep the feet to the fire of the member states that vote for resolutions, but I understand there's a small percentage that really get significant traction. How could we do better? Maybe it's how we write those resolutions with reporting structures and so forth, but you tell us.
This might be a question a little above my pay grade. But I've been here close to 2 decades, and I can tell you, yes, we do a lot of resolutions, and the resolutions actually come up from the technical work because there is a gap and something needs to be done. And the way the system works is as a resolution, but the resolution is coming from the member states. And as WHO and Secretariat, we are the Secretariat. And our job is, as Jim said, we put a lot of evidence out there. It's really our job. And Jim says, give the member states the evidence, show them what works, and let them have enough to go. So our technical work is really to really create enough evidence. And if there are just 2 countries, then it is to say what I'm sure things have changed. So there should be evidence that compares one against the other. There are mechanisms by which you can make it a bit more binding. So we have a 3-year reporting process. The NSWA is an annual reporting process. It does make a difference. And that comes down to the technical teams with the member states to be crafty and put in your word. It says urges member states, and then you slide it in. But those are the mechanisms. But at the end of the day, it's not because nobody understands it or has a debate on whether this is technically relevant. It does boil down to politics, physical space. And really, I heard something Makasa said, there are establishments, and when he said establishments, he meant something else, but it's also your way of working. You have to change the status quo, and so there needs more advocacy, I would say, and that's really your role in your partners.
So as an example, to get something on the agenda, something like the reporting out that's been required in a resolution, is that also an advocacy issue to get a member state to put a report out, say on, 68.15 to have reporting out, which is required every 2 years, but didn't happen? Is that something that needs to come from the member states to get it on the agenda so that those reporting requirements in the resolutions actually appear on the agenda?
So if you have to report on a resolution, you draft it within. You draft it within the resolution, and then the technical team is obliged to make sure the reporting happens. Yes.
Okay, that's great. Maybe one quick one. There are other people. Wait, your final quick one.
Yes, my final comment is on education. So during the pandemic, medical students were sent back. And then there was, this binge on Zoom and all these clinical things that were ongoing. But we need to close also that gap, because there's a generation of medical students that were left out, and they had to catch up. There's like medical simulators and a bunch of stuff out there, but it does not replace patient contact. And that's a true concern for this generation that was like caught in the middle of the pandemic.
Any comments? Carta?
Okay. Prior of being president of WFME, I was responsible for the Pan American Federation of Association of Medical Schools. And obviously
Thank you.
obviously all the different countries and from Canada, okay, United States and Mexico and all the way down, we started to talk about what was going on, okay? And we have Costa Rica as part of our group. And we start sharing the ideas that we started to find solutions to the problems that we were not training adequate our students. So we had, okay, the pandemic is going to pass in 2 months. Okay, so very optimistic. No, it goes to 4 months. Now we lost 7 months. And so what do I have to do? So then is when we started to make virtual hospitals. Okay, that's a model that was created in Panama and that was shared to all of us in Latin America to try to do something to compensate what our students were losing. And then we established extra activities, okay, within when they passed to the following semester or following year, we had additional complementary activities to complement what they lost in previous semesters or previous years. So it was an effort from everyone sharing our experiences and trying to make things come back. We concluded that our students are having some lacks of training, okay, at level of medical students, but the compensation took place when they go into internships, okay, or when they go into residencies, because everyone is aware of this problem, okay? So because we know that, we're trying to make all our efforts to assure that every student has the experience that they have to have when they are being trained. So that's the best we could do. And during that unfortunate period of our training of our medical students.
Thank you.
Thank you. Yes, in the back. Thank you.
Mikasa is taller than I am. Mark Schreim from Harvard PGSSC and from Mercy Ships. Dr. Rousseau, if you'll let me be a little bit controversial, who here is a nurse? There's 3, 4, 5 nurses. The question I want to ask, from the beginning of the Lancet Commission discussion, task shifting, task sharing has kind of been the solution to the global surgery workforce problem. But task shifting and task sharing is a bit of robbing Peter to pay Paul. In pushing for this as primarily surgeons, anesthesiologists, and obstetricians, to what degree are we creating an internal inequity, an internal brain drain, taking, increasing the pay of certain nurses to kind of move out of bedside nursing, et cetera? So is this part of the discussion in task shifting and task sharing?
Well, that's a very good question. And I might ask someone who is in the room, but not up here, Professor Richard Henker, who is an officer of the PC and will soon be the G4 Alliance PC president, who is a professor of nursing, to address that issue. You've got great expertise in this, Richard.
Thank you so much for that. And I know, actually, I'd love to have Dr. Gelb also talk about this. And he's actually an advocate for us in terms of our nurse anesthesia practice. And I think one of the things that, your point about task shifting, I think one thing we do have is we have a huge shortage of nurses. And I think we have to be careful in terms of how we use our nurses. On the other hand, I'd say that some places it's great to go ahead and have them practice to the fullest extent in terms of their scope of practice. I'm not sure I really like the term task shifting so much. I'd rather that we use the term, practicing to the fullest extent or have a well-defined scope of practice. In some places, we have nurse anesthetists. I work in Cambodia and Laos, and I work with programs there in Belize and Bhutan, and we've developed nurse anesthetist programs. And we feel that it really helps in terms of access to surgical care. I know there's always issues related to quality, and there's lots of discussions about that. And there's some evidence out there. There's been some great papers published. There's Mark Newton from Vanderbilt has done a great job in Kenya in terms of developing a program for nurse anesthetists, and it's increased access to surgery. And I think it's in Anesthesia and Analgesia. There's a nice paper that talks about how it increases access to surgery. So I think many of those things have to be considered. I think, you know, we really have to work on nursing workforce. They have to be considered part of the team. I think one of the terms that just makes me cringe here is the whole non-physician thing. Please recognize your nurses as part of the team. And, but I would love to hear Dr. Gelb's perspective on this, not to feel like I'm calling him out, but
I did you.
I have to tell, he's, I've always enjoyed having discussions with him, and he's actually very much an advocate. He spoke at our International Federation of Nurse Anesthetists meeting in Croatia, and he did a great job.
Thanks, Richard, for the invitation to the microphone. I agree with you about task shifting and task sharing. And I agree with Mark and the important question that we're just moving people around on the same board. I much prefer the term or the expression of team optimization. People need to work at their level of competency and training rather than a somewhat derogatory task shifting. I'm going to dump on you what I don't want to do, which I agree with you is offensive. So I think as a collective, we should adopt team optimization as a much better political term. The reality when one looks at least at the anesthesia workforce is that we cannot do it with physicians and nurses alone. You know, I like when I trundle around in different countries talking about workforce expansion, doing the arithmetic for them. India, to reach 0.4 per 100,000, needs 36,000 anesthesia professionals. There's no way they're going to
In whose lifetime? Yeah.
with physicians or with nurses. So we really do need to either rethink the arithmetic, and modeling people like Mark may want to take that on, or we need to rethink the models. But a problem we have at the political level between surgeons and anesthesiologists is a substantial disjunction between what we each view as high-risk patients. Simple hernia repair in somebody who's got a nutritional or alcoholic cardiomyopathy is not a simple anesthetic. It's a simple piece of surgery, or at least so it looks to me.
Yeah.
On the other hand, a complex piece of bowel surgery or some complex congenital anomaly in an obstetric practice in an entirely healthy individual, young woman, is a relatively straightforward anesthetic. So we need to figure out a way of having the conversation that goes beyond the utterly foolish comments I hear from lots of surgeons. Well, we can train a technician to do a hernia. Why can't you train a technician to do the anesthesia for a hernia? We need to get our heads around it.
Yeah, we say a lot of foolish things. Yeah.
Yes.
Thank you. We have, I think, time for one more question. Ambassador Jimmy Colker, would you like to?
Other people, I'll be very short.
Okay.
I'm Jimmy Colker. I'm a longtime U.S. government official, board member of the G4 Alliance, and now in remission from my government responsibility. We're not the only people thinking about health workforce. The leaders of the African Union have agreed to something called Africa Frontline First, which talks about training and hiring 1 million new health workers by the end of this decade. President Biden has proposed $1 billion, which is in the budget proposed to Congress, call it for a workforce initiative. But neither of those specifies anything about surgical workforce, anything about postgraduate medical education. This is mostly about community health workers or trying to deal with the backlogs of practice now. I'm just interested in how the panelists, especially the WHO, are going to find synergies in that, take advantage of it to address the problems that you've all identified in terms of surgical workforce.
So Tima, it looks like you're on the spot first, at least again.
Yeah, I just want to make it clear, I'm not the surgical expert here. And I don't even have a medical background. And I might have missed the question a bit, but I know that the WHO is at the table for many of these initiatives at the regional and the country level. So we're trying to work with the, stay at the global level, be relevant, and then when work and build capacity in our regional colleagues so that they can actually bring the issues that are more relevant to the forefront and ask for the money and direct the money to where it should go and makes more relevant decisions at the national level. That will be my answer.
Do we have time for another question, Dan? Okay, please. Thank you.
Hello, Catherine Moore from the Intuitive Foundation. I am coming with a fairly radical proposal in some of these areas because I'm a huge advocate for simulation-based training at the point of care. Moving away from centralized training for surgical procedures and allowing surgeons and surgical practitioners to train themselves with self-administered assessment at the points of care. They know how to do one surgery and can train themselves to do the next one that is needed. It has a huge implication in terms of how we accredit this sort of thing, the quality of this training. We've been able to take many clinicians through self-administered training all the way to clinical with simulators that they were able to make out of locally available materials and practice to mastery. But it's going to take a radical rethinking of the way we think about who trains, who gatekeeps, who decides what is quality. But we can scale education in this way. So I'd be interested in the panel's thoughts.
Ricardo, that sounds like it's directed toward you and quality. You want to at least start the response? Who decides what's quality, basically?
Okay, well, the quality issues are responsibility of the medical education systems, okay? And they come from the university, and normally they're regulated by these issues. So if you want to respond to the quality of a training program, it has to be done through standards that they have to follow and be able to accomplish what they say that they're going to accomplish.
So full disclosure, I've run the simulation center at Stanford and written most of the simulation-based curriculum for training surgeons in several capacities. So it's not that it's not coming from an academic background, but it is really more when you take it out into the community where you need to deliver care and you can no longer bring people back to a central medical school. We've heard from other people, the most precious resource that we don't have enough of is the master educator. We're tripling up 30 trainees to one educator in order to be able to try to meet some of these targets. Could we allow self-administered assessment under these auspices to be part of how we scale that?
Okay, I believe that the simulators have evolved dramatically. Okay, if you have had an opportunity to sim the new simulators, it's impressive what you can do with them. So obviously, if you have the assessment system to be sure that those who are going through the self simulation process is adequate, there should be no problem. Because as an example, if you're going to learn how to make laparoscopy, okay, and you start working with your equipment and seeing and every time there's more reality to what you can accomplish with your laparoscopic equipment, you can do very well, okay? So if this student train or this resident trains well with that, and then they took him to a real patient and he achieves accordingly to what you are expecting and according to your goals, that's perfectly clear and is good. But again, it has to be supported. Like in your institution, it's a very well-known institution that knows that the quality, how it has to be assessed. and there's no problem with it. The problem comes when you go and try to make a self-evaluation process in a medical school or in a residency program that doesn't have the adequate resources or doesn't have the right assessment. And then what kind of a physician are you releasing after that kind of training? So it much depends on the resources of the hospital, of the environment. And then the other thing is, okay, you learn how to make the process with the most sophisticated techniques. And then you take into a rural community hospital where they don't have all that equipment. So what did it actually work for? Okay. It's like what happens in Mexico. I'm from Mexico. Okay. So you go to a tertiary hospital, you learn all these techniques, and all of a sudden they say, okay, now you have to go to rural Mexico. And you go to rural Mexico and say, I don't have nothing. How can I practice if I learn this? This is the way it should happen. So there's a lot of things involved in all this discussion. And from my perspective, okay, it's something that the government, okay, should provide the resources to go into the communities, okay? But normally the governments get the resources for the cities, okay? They don't give it to, and that's why most of the physicians don't want to go to rural areas. There's exceptions. Obviously, here we have Genevieve from Canada that have a very good community service for their population. But for Costa Rica, from my friend here that mentioned, we don't have that, okay? We don't have it in Mexico. We don't have it in Latin America, okay? That's where I can tell you because I know that area. And obviously, by just hearing what is going on in Africa, well, the same thing will happen. But it's an excellent training process if you're going to continue within the same level into a nice hospital where you're going to have all the resources to continue what you learn in a simulator.
And it's an excellent discussion to continue over adult beverages and food. So with that, I'd like to really thank our panel very much and the audience for some great questions. And there's lots more to talk about. And I regret that we couldn't have the panelists answer all the questions, but let's continue this conversation. And thank you very much. Dan, do you want to say, we just want to mention what's up here on the screen? What else exciting is happening here in Geneva at this WHA, which is our next event, which our next G4 Alliance sponsored event will be tomorrow night in this same room at this same time. And we will at that point be looking at going from resolutions to reality, bringing surgery and anesthesia into primary care. There are a number of other important events that G4 Alliance member organizations and working groups are going to be sponsoring. So please talk about them over drinks and refreshments. And thank you again.